Shall we?
All right.
All right, so also I guess we'll maybe kick things off, but try to focus as much time as possible on audience questions. So feel free to queue up and interrogate our speakers. Maybe one question is a lot of material in talks describe technologies developed kind of independently at separate health systems by folks within those health systems for use by doctors with those systems. And that's one pattern of producing technology. Is also a lot of shared technology. We don't want every hospital system to invent their own EHR, although there was once upon a time where that was the thing people did, and kind of a disaster. We don't necessarily think that everyone in parallel needs to reinvent sort of medically tailored speech recognition. And maybe a high-level question would be, when do you think that maybe appropriate path or productive path for technology development is a set of independent efforts at different health systems versus the sorts of problems that are more primed for a centralized actor to take out the problem in a way that would be sort of universally applicable across the nation?
Sure, great question. Do you want to take a stab? You want me to go?
I'll give our perspective because our perspective is get stuff done at our hospital. We have 3 hospitals, and we need to do some individual work because just 2 of our hospitals on opposite ends of Queen Street here just are not the same. So we do need to tailor some bits from the technological perspective. The engineering stuff is recycled, but some of the modeling things are not. But if you can plug in some kind of slightly customized model, this is helpful.
Can you give an example? It's a nice example of like same system, 2 hospitals across the street. What actually, like, do you have like a kind of case in point example of like something that worked at one and not at the other?
Not necessarily works and then doesn't work, but works differently. So the tools which we're actually going to be turning off at some point soon, ED volume forecasting, so just knowing how many people are going to show up today, just like different models for the 2 sites, because the emergency departments of the 2 sites are just different. They work differently. The way people use those tools are just different. So they have some level of customization that I think to users are like transparent. They don't know, they don't need to know. But to us, we do know that there's something here that needs to be customized. But we will, when possible, try to take things off the shelf from other larger sources if we can.
Yeah, maybe a final follow-up on that is like, is that not a case where you could have the same software system, the same algorithm, the same everything, and it's merely an input is a trailing series of ED volume over the previous some time period, and it's merely the inputs that are different, but that the technological bits are shared? Or do you think that like you actually need a separate modeling effort at these 2 hospitals?
Sometimes separate modeling, certainly separate workflow integration.
Interesting.
Yeah.
So I think about this in a slightly different way, which doesn't conflict with what you're bringing up. Think of the point of personalization. Each site is different. There's no doubt about it. And we all talk about personalized medicine, right? I mean, that's sort of we talk about personalized medicine, but we want standard operating procedures everywhere, which is kind of an oxymoronic in some sense. So some things are obvious. Like, we're not going to try to have our own implementation of, say, the SSL protocol. The world uses the same. And at the other end is that if I'm going to build a readmissions predictor, it is going to be very site-specific given my patient population, the local socioeconomic characteristics, and so on. And so there's no expectation that a readmissions predictor generalizes from your hospital to mine, because the inputs to that are very specific. The intervention is going to be site-specific. But we apply the same mindset to everything. So I think the question to ask is, what is it that needs to be localized or personalized, and what is it to be shared? Okay, so how do we arrive at that? I think in terms of of a word that the business people think of in terms of total addressable market. If I'm going to build something that's only going to be used by 5 people, it does not make sense to do it as a company. And if I'm going to build something that's only going to be used by 5 people, but there are 5 people like that at all 6,000 hospitals, I better do it as a company, because otherwise it makes no sense for 5 people at each of those 6,000 hospitals to do it. Now, identifying that classification boundary, that what is it that is going to be needed by a few people everywhere, is the hard part. So that's the way to approach that. And then the caveat being there will have to be some sites, particularly academic medical centers, that will do crazy stuff that makes no business sense. We would not have invented the heart transplant if there wasn't a surgeon who thought, like, I can do it, nobody else can. And now we have it. So we have to think of it as an ecosystem. The innovation ecosystem will always be like crazy stuff. You could legitimately question, why are you doing it? It should be shared, but pushing the envelope resides there. Once you have proof of concept, then ask the question, is it going to be used by everybody? Turn it into shared infra, spin out a company. And recognizing medical speech is one of those. Like, I don't think people should be writing their own speech recognition models. We're at that phase that if you do that, it's like writing your own SSL layer. I mean, you could, but like, why?
Well, we had to at a bridge because all the commercial medical speech recognition sucked, but we're also deployed across the nation.
Yeah, but see, you had to do it because
now everyone should use ours.
The core thing happened as a crazy thing as an academic.
Yeah. I think this is the first MLHC panel to talk about TAM, so it's a milestone. Maybe one last question before we open it up. And you, Derek, in your talk, you talked a lot about, you showed this like example of, I think it was like a kind of like a requisition for new technology kind of form, and kind of pushing people to be precise about outcomes they're after, metrics, quantitative goals. And maybe another theme, Nigam, in your talk, you talked about like, are you impacting mortality or impacting money, and by how much? And I guess one interesting tension is that on one hand, like the appeal of like state a real concrete freaking quantitative goal that we can measure is probably something that doesn't need to be justified to this audience of quantitative-minded folks. But a danger sometimes is that we end up focusing really myopically on those things that we have good measurements for, and things that are important but not easily measured. And you see this show up all over the place. It's why we have lots of uninspired, I don't know, why we focus on a lot of the wrong attributes in student applications, because it's easy to measure a number of publications and it's hard to get at a lot of intangibles. Mm-hmm. I think in healthcare, I would say like outside of, like mortality is measured well. Money is measured well. Quality of life, the experience of patients suffering from like, autoimmune diseases, for example, is not measured well. It's not captured quantitatively in a particularly useful way. And so I guess how do you balance the focus on the measurable with some amount of obligation to produce useful technology in spaces where maybe the innovation that's required is measurement in the first place?
Mm-hmm.
So I actually had a slide on that which I took out, figuring I would not get this question here. We at least think of it in stages. There's things you do to establish feasibility, that can this work? At that point, let's call it a proof of concept, pilot, whatever you want to call it. At that stage, asking questions about lives saved and money saved is premature. In fact, it would hurt you and rule out a lot of innovative inquiries that will not begin because you prematurely apply a forcing function on it. So that Wild West, you have to time box it and resource box it. I have no problem students doing crazy bets. But we don't want our professional IT staff doing crazy bets, and then when it comes for budget renewal, they can't show what they did. So innovation, the only readout is, can it be done? Next stage is, can you define and verify its value proposition? Again, you're not going to save lives or money at that point, but can you prove that the value proposition exists? That's the second stage. At the third stage, if you can prove that it's feasible, and yes, it's going to increase efficiency, productivity, what have you, happier patient, happier doctor, then you have to tackle the problem of scaling, which requires not just technology scaling, but changing the way the business works. You have to do business model change along with technology change. Otherwise, it doesn't happen. This is the MBA 101. Like, every month I meet with a business school professor who sort of gives me some nuggets. This is
Don't
one.
meet with business school professors.
What?
Don't meet with business school professors.
And so scaling does require a different way to organize your work. I would not do those kinds of things as PhD projects. Stick to the first two.
Final thoughts before we open it up?
So to your point, sometimes take swings. So some of the stuff I actually showed, like, didn't really go through the intake form in the same way. It's important to actually, like, I know we're all quantitative and we think quantitatively for evaluation, but it's good to have people that are experienced with qualitative. If you can get like a vibe check from a lot of folks that something is important, you should probably go with it. So yeah, some of the tools I showed did not go through that form in the same way. And you look at the form like, you didn't fill in anything. But there are things here that are important, and by connecting with people, a lot of people, so like these medical imaging deployments in particular, we know they touch so many departments and so many people that there's something much bigger there. So just hearing what the people on the ground are saying is another way of actually getting through this without like sticking to the box of like, yes, please go through all my form and make sure you fill it out.
Yeah, you got to walk the rounds. You got to know the place where your tool is going to be used.
Yep. And then take swings.
So let's get to some audience questions, and let's try to see if we can get through a bunch of these. And I guess depending upon who the question is addressed to or whatever, we don't necessarily all have to hit it, but we'll see if we could chew through this queue. So, my friend.
First off, thank you both for the excellent talks. My question is about evaluation. And I really love the discussion on what metrics and what we're measuring and things like this. Very important, but for the purpose of my question, let's imagine we have the metrics we care about. But I'm interested, primarily, Derek, in the concern you raised about as things change over time, how do we continue to evaluate, continue to understand, continue to retrain? And so I'm curious from both of you what the sort of perspective is on what does the roadmap look like for us to develop the tools to actually evaluate these things effectively over time in the context of many models being deployed. What does the future there look like, given how fundamental that problem is to actually deploying these things in a rich ecosystem at scale?
I think a lot of it's there. Complex systems and causal inference and directed graphs, like the building blocks are here, but it's, I think, a non-trivial thing to now like take out of these different fields from some theoretical, some applied perspectives, and how do you embed this into these systems? So the future, I think, can look towards the past quite a bit. Like a lot of the foundation is here, but to the point before, like I don't want a PDF, please help me, put something on GitHub. I need to just use it.
I'm waiting for that problem to become something that gets mentioned at the CEO conference for Hospital Corporation of America or the Hospital Association of America. It is a problem that it would be nice to have. That means we as a field have succeeded.
Yeah.
Thank you.
Thanks.
Professor Oberst.
Thank you both for the excellent talk. Lots of good work talking about quantifying benefits, so I'm going to stay on that thread. My question is generally, what do you see as the role of randomized trials for machine learning models? And for a little bit of context, I mean, for the broader group, obviously a lot of this is measuring the causal impact. I've deployed the model, and because I did that, I reduced readmissions, et cetera. Randomized trials give you some sort of gold standard understanding of that, but they are not without challenges. It's obviously extremely logistically challenging. There can be ethical questions. And so I'm just curious from your roles as people deploying models in practice, do you do randomized trials of the things you deploy? If you do, how do you decide when to do them? How do you make some of these trade-offs around when it's sort of worth doing a trial or when the benefits don't outweigh the costs?
RCTs, WTF, go.
We're mostly pre-post because there's like the other side of that ethics question, especially stealing something from like ML and stats, like A/B testing. Like, are you really gonna not give this to someone if it seems to be working? And that's why we put a lot of effort into like that silent deployment phase, where there is validation, people can see it, but nobody's acting. But that being said, there are almost certainly other better or alternative and complementary ways to do this. But what is the right way? What is the best way? I truly don't know. Yeah, it's tough to say like, no, you can't have this intervention, but you can.
So RCT, the word randomized controlled trial, comes with a lot of baggage. And so as a very tactical point, I would stay away from that nomenclature purely for the reason that that then invokes adjudication committees and protocols and multi-site and generalizability, and sort of puts you in the mind frame of you are testing an intervention, a molecule that is going to be tested once and used forever without question. Costs too much. So the act of doing a prospective testing in a comparative setting, often called an A/B test, that is worth doing. But I wouldn't pick up the rule book or the rituals of the current randomized controlled trial community as constituted, because, and this is in the words of Mike Lauer, the head of NHLBI, it's a parallel universe and it's an expensive universe. They test things in environments that do not generalize, and for these machine learning interventions, a lot of whom are going to be using operational inputs, what is the scientific basis even to insist for generalization? Then if not, why on earth would you do a multi-site trial for a readmissions model? It makes no scientific sense. But the intent of designing an experiment that gives you a causal readout, that's the nugget to pick up. And that you can do that by a well-done prospective observational study, a before-after study, or even crossover designs in your institution.
Like a discrepancy between what like causal academic community like means when we just say RCT is just randomization versus the baggage attached to it in a context of like medical RCTs.
There's different ways to get to causality. Like a child never proves who's their mother by doing an RCT.
I think one thing that's interesting, is a quick nugget, is owning a live software product. I mean, think of A/B tests as like you are in a situation where you're in a position to do experiments, to do them at relatively low cost, to do them frequently, and to think of any deployment essentially as an intervention. But I guess the weird thing is, in RCT, you have an idea that, like you were talking about, you have some molecule that like, you will deploy, and that same molecule will be like, aspirin will be aspirin, and it'll be aspirin 100 years from now. And software is a weird sort of intervention. Mm-hmm. And software is being updated often on like a daily or weekly release cycle, at least for small changes. And like, what is the sort of step size in terms of update that like you now should think of yourself as having a different intervention? Like, is it a small change in the post-processing of the speech recognition system that increases like the recall of medical terms? Like, does that require that you now run a whole new A/B test to feel like you have a handle on outcomes? And if not, then
it's a tough problem, but I wouldn't go down the RCT path. Doctors change protocols all the time. It's a Word document that 3 people get in a room and change it.
But you do believe in randomized experiments. You're using the word RCT with a lot of baggage attached to it. Like RCT as in like statistician saying RCT versus observational, you're down with. But you wouldn't go down the path of.
I wouldn't write a multi-site protocol from central IRB and go for NIH funding for that.
Got it. Anna.
Hi, this question is for Nigam. So the project where you're answering questions within 2 days, I'm curious, how do you evaluate that your answer is correct, right? One of the things with reviewing papers is that somebody sees it and, somebody who was not involved in the work, and might be able to evaluate it. That's question number one. And for the same sort of project, are there questions that people come to you with that you say, I cannot answer this within any reasonable amount of time?
Yeah, so I'll answer the second one first. In the pilot we did, out of the 100 questions, 17 times we said we can't answer the question. Like, you need a way to stop and basically excuse yourself, 100%. The first one is a little bit harder. We did a couple of things. The simple ones is you go get a set of known truth and ask how often can I recapitulate it, and you create a set of known untruths, aspirin being associated with left foot fracture but not with right foot fracture. Test those and count how often do you say, yep, that is correct. So we can empirically estimate the false discovery rate and empirically estimate the true positive rate, but true positive is harder because you're limited by, I've had instances where we deemed something a false positive and then subsequent experimentation confirmed it was a true positive. But when we did the study, it was deemed a false positive. So those two, so you basically do empirical calibration. The second is you can look at concordance. So you can ask the same question on Stanford data, Truven Market Scan, and Optum, and ask how often do you get directionally the same answer. The concordance ranged from about 68 to 73%, depending on exactly how you define it, which is the exact rate at which RCTs, the ones with the baggage, have concordance with each other. And then the third thing is to create prospective observational truth sets. So from clinical trial reports, you can look at the adverse events that they report during the trial. And for the drug adverse event association, the trial is merely an observational study because it wasn't randomized for that. And then we created and released a data set which we call trial probe, which then allows you to say, given my data, at what threshold will I recover what kind of effects? So those are the three ways in which we evaluate it.
And you give back uncertainty to them as well?
Yeah, and you can do falsification testing and estimate the probability of being wrong in whatever you report.
Okay, thank you.
Okay, we have a few minutes left. We'll try to rapid fire here. 20-second version of the question.
No problem. All the stuff we do uses EHRs. The majority of the stuff we do is actually a fairly inaccurate representation of what happens at a clinical level. Are there data that we should be collecting that we aren't, that are going to make things better overall for the prediction models and things we're using?
Patient-reported outcomes.
Speaking from here, like, we're not collecting key demographics. Like, they're just not in the system. Like, that would be vital for us.
Sorry, I totally agree with you. Is it more like actual things that what's happening in the hospitals, more like that?
Yeah.
Are the things that we're not even interested or looking at the moment that we should be collecting, like number of people in the room or amount of armpit sweat on the doctor at the time, Are there things like that that's going to make things better for us?
Almost certainly. I don't know the conclusive answer.
Every piece of data you collect costs something in time, money, and energy. So I would be very careful before asking more things to collect, given that right now people are already complaining about what they have to collect.
Yes and no. So I'd say, like, speaking a bridge hat on, one thing that's striking is when you look at a transcript, how little of what's just spoken out loud between a doctor and a patient actually gets captured as structured data. And we're actually living in a moment of opportunity that just what's already there for the taking, potentially to be leveraged, isn't being captured, but could be in an automatic way that it's I think a real opportunity to capture a lot more structured data with almost negligible additional cost. But we just have to do the work.
Thank you.
Hi, my question is a little bit practical when deciding which problems to solve when you're a technical person in a clinical setting. I'm in an academic setting. You mentioned there's, you measure the efficiency, is it possible? But often some clear list doesn't emerge and there's a very high demand. How do you make decisions on which problems to solve first and what to prioritize?
So that depends on a couple of things. I mean, one.
Look at the TAM.
What? Well, no, it depends on the career stage of the person as well. I mean, and where you're geographically located. Do you even have a hospital nearby, and so on. So it's a very tough one to answer in the absolute. The criteria to look at would be the science, practice, delivery. Are you solving a classification prediction problem or whatnot? And then do you even have access to tackle some of them? Like if you're at an elite engineering school, and I'm just going to pick one like Caltech. Caltech doesn't have a hospital on its campus. Like it's really hard to do a prospective study of a prediction model if you're working there. And so you'd have to color that based on practical constraints. Career stage-wise, like if you're a graduate student, I wouldn't take on things that move financial outcomes as a graduate student because you do want to graduate in finite time, and those kinds of things can take a while. And so there's a couple of concerns to define what comprises a good project.
I was more like assuming a bit more like Derek's role, where every problem is coming to you quite well defined, does actually have clinical value. There's just too many of them to solve.
Oh, then people. Are the people coming to you
coin flip?
committed, and do you like them?
Yep. Are we going to get this done, and what are we expected to deliver on at the end of fiscal year? Is like some of the very blunt and honest answers here.
If they're good partners, take it. Even if
exactly.
All right. In the interest of coffee break, I'm going to keep us going rapid fire, and we'll get these two, and then we'll adjourn.
So what are your, this one's more for Dr. Shah. What are your tips to making more generalizable models now that you've brought up how, like, if you make a multi-site one that's for readmissions, it's a terrible idea, but that kind of limits your own scope in terms of how far your research paper can be applied, because if you only make it for a single site, then it can't be applied to anywhere else. So what are your tips for like choosing which metrics in order to optimize so that way your paper is more likely to be a little bit more generalizable to other hospitals?
I'll cite a publication. Alex Yusuf, Mike Pensina, and a few others and I have a publication saying we should replace recurring local validation should replace external validation. And it outlines all of the points on why that should be the case. That will give you some ideas for the metrics you could use in doing recurrent local validation to prove that your model is indeed good.
And this guy.
So I have a question from Nigam, and this is if you could give an advice to academics who might still not be bored of the profession in terms of what a successful or a good PhD project, if they have to recruit a graduate student, would look like in the context of, say, 3 years in this space, and where a model that might have worked or still works is that maybe you work with a clinician, you define a problem, you do your literature review, you access data, you develop a model, and then you have externally validated on a different data set. And for context, I'm from UK, so we do have access to countrywide data sets that primary, secondary care, medication, they're all linked. So we have those resources in medical school. I mean, that's all covered. But the problem with the state we are in, most of the models, that's the end of it. It gets published and that's it. Mm-hmm. So given that background, that's how we have been doing for more than a decade. What would you like to change in this, or what is feasible given this would only be 3 years and that would be the funding end of it? Any advice?
Yeah, I would, as a student, I would not build models anymore. Instead, focus on creating benchmark data sets for verifying benefits. If you have access to that level of good quality data, figure out a strategy to create a subset of it that can be shared. And then benchmark 10 models. And the metric that you use to benchmark them, tie that to something meaningful in the health system. I think we're underappreciating in the healthcare community, or machine learning in healthcare community, the value of shared benchmarks. I mean, CS Advanced, there's so many shared benchmarks that led to massive progress. We don't have those in healthcare. So I would focus on creating those. And in 3 years, you can create a good shared benchmark for a particular task. And those things will get cited too.
Thanks.
Well, it is now time to drink a bunch of coffee. Please join me in thanking our speakers, Derek and Nigam.
Thank you.
Yeah.